So this is another misconception that is commonly thing, and to be very honest, I didn't know it till I was in say MD general medicine. So this is our normal kidneys. Normal kidneys produce your urine, and it comes to the blood and passes out urine. I thought these kidneys will be removed and transplant will happen, but the
Even
actual
I do
truth
thought the
is,
same, doctor. I do thought the
so
same.
even I didn't know, even till MD, I didn't know this.
Yeah.
So we don't even touch any of this. We keep an extra kidney here, and then we attach the ureter to the bladder. So this is another thing that many people don't know. Many of us also don't know. Many of us, I'm sure, even other fields in medicine also will not know that the third it's kept as a third kidney. And the reason why this is done is even with the kidney is in place, around 5% of kidneys will continue to function. It's even on dialysis, around 5%, around 100 ml of urine. Some people have even more amount of urine being produced. And we want to try and bring out as much function of the kidney as possible, which is why we don't meddle with any of this. We are okay with the kidneys being there. There are only rare conditions when we take out the kidney, wherein there is some infection which is not settling, where the kidney sometimes due to certain conditions are very enlarged. So you have a large kidney, you don't have place, and there are specific indications. I don't want to go into the details, but in such conditions you would remove the kidney, but otherwise it is always a third kidney that is transplanted. So this is another misconception, something is very interesting to note. And to slightly talk about the history of your transplant. So first thing, the luckily the first transplant happened between identical twins. So that immunology, that rejection, all of those concepts never happened. And from there on, now we have around 50 years, 70 years later, now we are into this entire new world of transplant where we have a lot of drugs which prevent rejection and we are worried about rejection. We'll talk about rejection a little later. But so this is your transplant, how it happens. So if somebody is on dialysis and say her father wants to give the kidney, we have a lot of battery of tests that we do. We kind of run through these tests for both the donor and the recipient. If they're completely fit and we get all sanctions from the hospital as well as the government, we go ahead, we remove the kidney from this patient and we place it as the third kidney to the recipient. And once that happens, and what's fascinating to note is that somebody who was producing less than 100 ml of urine per day will end up producing 1 liter of urine per hour. And that is how, that is what, is every nephrologist's dream, is what we say, looking at that euro bag and seeing so much of urine coming out. So the other thing is this kidney doesn't have brain regulation. It's kind of a denervated kidney wherein you will not have complete regulation. They will not know. They just basically throw out all urine that comes to the kidney. So we end up marking urine output of 22 liters per day, 18 liters per day. As the urine keeps coming out, we keep putting in more fluid, more urine out.